Malice. That was effing awesome. So our second speaker is Miss Zoe Welton. Zoe is the National Sales Manager for Regional Anaesthesia at Braun and has travelled all the way from Sydney to also share her insight into intrathecal prilocaine from a pharmaceuticals perspective. Would you all please welcome Zoe?
I definitely won't be dropping the F-bomb, just for anyone. Okay. Hi, everybody. My name is Zoe Welton. As you know, I am the National Sales Manager for Braun. I just want to talk today a little bit about prilocaine. Prilocaine comes in lots of different forms of how we say it. So, based on the PI, the average duration we're looking at for this product is 100 to 130 minutes. This is based for adults of an average height and a weight of 70 kilograms. And to highlight the advantages of the product from our perspective, and nothing ever takes over from your perspective when you're using it on a patient, but we can obviously only go from what we've had before in the UK and everywhere else around the world that's using the product at the moment. The first advantage is the evidence that supports the product, but reducing time to discharge, which we've just been talking about, which is one of the main aims of the game at the moment. Also reducing time in post-anaesthesia care unit. B, by giving you more time in the OR, which is the biggest cost saving and for most clinical settings at the moment. And C, helping you to adjust your discharge criteria, especially for post-operative urinary retention. Sorry, it's giving me different screens than I'm used to. So faster patient recovery. I know, Miles, you covered that, which is great from your perspective as well. It's great to hear that that actually is working. Nothing is ever going to be perfect, especially when you have a time frame to work to. But advantage of faster patient recovery, particularly important for orthopedic surgeries. ARAS guidelines support the use of medications which have minimal operative hangover. You guys know that already, and minimal effects of gastric mortality. Thereby, outpatient surgery is possible on a broader scale, and prilocaine for short-acting spinal anaesthesia brings these advantages to the table for you. So we're not trying to reinvent the wheel. We're not trying to take over from anything. We are just trying to give a message of right drug, right patient, and the right procedure. If we get this philosophy right, and this is Dr., and correct me if I'm wrong, Tom, Dr. Erskine, it's what he says, and he goes around the world saying this, and I think it's really important to remember that this is not for every patient, and it's not for every procedure. It needs to be tailored for certain procedures and certain patients. The product is hyperbaric and is associated with low incidence of TNS, fast onset, although Miles might tell you a bit different. Generally fast onset, intermediate potency and intermediate duration of action. But obviously when you're using it, again, it's something that we are keeping track of. So when this product goes out into field, we really want to make sure that we're getting feedback from everybody to understand what the product is doing, what variances it has or not, or what's helpful for you guys and for us to help you. This indication is for adults only, at short-term spinal and short-term surgical. I keep going over that. It's really important to keep going through those notes. But the option of the unilateral block due to the hyperbaric properties of the product is also available. Contraindications. So we will send out some information after the fact today to go through all the contraindications, but to list a few, you can see them up there. Serious problems, cardiac conduction, severe anemia, cardiac insufficiency. These are patients that we wouldn't use this product for. But again, your local specialist, Lishka, who's in the room, will be able to help you with more information on that. I don't need to read off the slide there. You guys can see that already. So prilocaine versus LA. Hyperbaric prilocaine 2% was superior in this study to local anaesthetic 0.5% due to a shorter effect profile, but otherwise equivalent quality of a block. I will send some of this information out to you guys as well. So as I've mentioned in the previous slide, low urinary retention, low incidence of TNS, as you can see on the top right. The incidence in TNS greatly depreciates in percentage versus other local anaesthetic you can see there on the right-hand side, the clickable there. So we've got more than 10 years experience with this product. This isn't something that we've just brought into the country overnight. It's been used extensively. The first registration of the 2% was in Germany and Austria. We have 10 years of learnings and information that backs up what we're saying today. We have 27 countries so far that have registered for this product, and with more in submission. Tacropril is prilocaine, so you'll see a lot of different ways of saying it, but it all comes back to the same product. And 1 million doses worldwide that have been used so far. That's probably a bit out of date now, actually, as well. So how can this product help you? I know Miles obviously went through this as well, but it's really good for the elderly, your elderly patients, the patients that are at risk with cardiac risk, patients with difficulty of ventilation, obese patients. And also paralysation can help you achieve better patient throughput. So your timings are obviously a bit better. You can actually get people in and out a bit quicker. The patient is awake, so less risk associated with the GA. Risk of mortality decreased. Typical complications with your GA associated intraoperative hypertension, easy for me to say, and tachycardia reduced. And here, short-acting spinal anaesthesia may help shorten or even skip PACU to allow creating more efficiency in the hospital. So this is one of the main slides that I really want to draw attention to, and it's the pain management. And Miles, you actually went over it, which is awesome as well. Early pain management is crucial in short-acting spinal anaesthesia, making sure you consider preemptive analgesia for your patients, ensuring the patient is comfortable and the outcome is as pain-free as possible. Managing that pain early and efficiently reduce incidence of post-dural puncture, headache by using atraumatic spinal needles. You guys know all this already. It's in there for me, not for you. Consider preemptive analgesia, briefing to reduce inflammatory pain and surgery and opioid consumption. And start early treatment of post-operative pain on the PACU ward. So there have been studies, it's obviously a knee arthroplasty, but we've just been through that with Miles as well. And just bear with me, because there's a lot of long words in here, which I have to say all at the same time. But a prospective double-blind randomized controlled trial of 50 patients undergoing elective ambulatory arthroscopic knee surgery received subarachnoid anaesthesia with prilocaine 20 milligram and fentanyl 20 microgram. And patient B were plain bupivacaine 2.5% and fentanyl 20 microgram. The conclusion of this study was that the combination of prilocaine and fentanyl is a better alternative to that of the low-dose bupivacaine and fentanyl for spinal anaesthesia in ambulatory arthroscopic knee surgery. So maximising the benefits, 5 critical points. Let me just go back there. Team setup, everyone needs to know that there's a different product being used, and so obviously making sure the surgeon knows and all the staff know that there's a difference, and also the PACU afterwards for the patients. Parallel workflows, so paralysation could help you achieve your improved patient throughput. Managing patient fluid intake, you guys know more about that than me. And managing pain. I'm going to go back to the pain management because it's something that has come up already in some of the states that we've been using this product in. So again, it's just making sure that you're considering the options and that you're not going from a 0 pain to 10 straight away when they're in PACU, and that's going to affect your nurses as well. And get them screaming at you, I'm sure. So how do you get your hands on it? So not as hard as Miles has had it for the last few years, but we definitely have it available. Has to be on the formulary for the hospitals. Order the stock via Symbian, which is our distributor, and the product evaluation. If you are going to use the product, please reach out and let us know so that we can actually get your thoughts and feedback on this product. It's really good, bad or indifferent. We really want to know. And that is it from me. It's very daunting talking to all of you.